Picking things up here back in the middle ear space. Sorry about that. We recall we had a pinna out here. We had the ear canal here. This stretched piece of skin right here is the eardrum, and the lateral surface of the eardrum is consistent with, kind of formed from the same skin as that lining the middle ear space. And as I said last time, the medial surface of the drum is consistent with this mucosa-lined skin of the middle ear, of the so-called tympanum. Now, last time we had mentioned these three bones, the so-called ossicular chain. Here we see them in more detail. So there's the malleus, the incus, and the stapes. Again, these three bones form what's known as the ossicular chain. And we also wanted to recognize that there are these very tiny ligaments holding those bones in place. This is very stiff connective tissue that makes this middle ear system, along with a couple other factors, a stiffness-dominated system. And so because it is such a high stiffness system, we would expect that it would, again, have a high pass characteristic with respect to sound going through it. When we look at the physiology of the conductive system, we will see how that is indeed the case. Notice also this tube right here. This is the so-called Eustachian tube, which connects this middle ear space to the back of your throat in what's known as the nasopharyngeal region. And we'll take a look at some different images of that in just a couple of minutes. Now, if we were to look from the middle ear space out toward the eardrum, this would be the view. Here's the Eustachian tube coming off of the middle ear space. This is, of course, the eardrum right here, and you can see how these two ossicles fit together, where there is actually a facet in the incus to hold the so-called head of the malleus. And that's actually a joint that connects those two bones. Here again are those ligaments, which add to the stiffness of the system as they simultaneously allow these bones to vibrate fairly easily. This part of the incus coming down, you see this little part sticking out right there. That would actually be sticking out toward the viewer, towards us, or in toward the center of the middle ear space. And the stapes bone would fit right on top of that. Notice also this large nerve that runs right along the wall of the middle ear space and actually sends a branch into the middle ear. This is the facial nerve, or cranial nerve 7, and this branch is called the chorda tympani, and it goes to the tongue, where it innervates the anterior, the front 2/3 of the tongue, for the sense of taste. There are a couple of large important structures near the middle ear that we will look at more closely again in a couple minutes. One you can see right here is the carotid artery, which of course supplies all the blood that's going to go to the brain on whichever side of the head this is. So obviously a very important structure there. So we'll see how the middle ear has a lot of important structures immediately around it, in addition to all the stuff that it holds inside of it. Okay, now let's look from the outside, from the lateral toward the center. Here we were looking from the medial angle out laterally. Now we're looking from the outside in, so we're looking medially here. And somebody was kind enough to actually cut the whole eardrum out for us so we could get a nice view inside there. And again, here's that long process of the malleus. Here's that chorda tympani nerve winding its way through there. Here's the incus. Now you can see the stapes bone fitting into an opening in the skull. What we also see here is a little bulged out area, which is actually the cochlea bulging out into the middle ear space in a region called the promontory. And then down here is another opening into the cochlea. So there's actually two of them. This one is the round window, and we've already talked a little bit about how the stapes footplate fits into the oval window. We're going to look more closely at all of this now to kind of put all that together. Sometimes it's helpful to think of the middle ear space, the so-called tympanic cavity or the tympanum, as a box. And you see there are a bunch of important structures running right around it. Here's the jugular vein. Here's the carotid artery that we mentioned before, the facial nerve. If anything happens to the facial nerve, the result will be paralysis to the facial muscles on that side of the head. We saw the round window in the drawing right up there. And then this is the so-called oval window, which is actually where the stapes footplate fits in. And I've got a nice picture of the stapes footplate in a couple of slides from now, so you'll see how that looks. But it is oval shaped, and keep in mind, the stapes bone is called the stirrup for a reason. It looks just like a stirrup, where there is a part upon which you would put your foot, the so-called footplate. And you'd see how that could actually, angled slightly, fit right into that space right there. So these are actually two holes in your skull connecting the middle ear space to the inner ear space. And when we look at inner ear physiology, the value of having those two openings will become clearer. That'll be in about a week or two. We also see the Eustachian tube, and frankly, I prefer to think of the Eustachian tube kind of as coming out from further down toward the floor of the space, and we'll see other images that support that. I think they put it up here just to get it away from the carotid, but in any event, the Eustachian tube is going to be another important structure that we'll want to look at. But what I want you to get a handle on here and appreciate is that there are some very important structures, not just for speech and hearing, but for life, that are running through or immediately adjacent to the middle ear space. And the reason I think this is important, and the reason that I want to highlight this point, is that the middle ear space is very prone to infection. And the bony capsule surrounding the middle ear space is not particularly thick, so it is possible in some cases for infections from the middle ear to spread to other structures that may even have some influence on a person's health, well-being, not to mention their life. For example, right up here, right above the top of the middle ear, would be the meninges, because the brain is just right up here. So an infection that accumulates and maybe even spreads into this mastoid antrum through this opening can in fact produce a chronic enduring infection that could even lead to something like meningitis if untreated. So middle ear infections are pretty serious business, not just for speech and hearing, but also for the health of the individual. The middle ear, again, if we picture it as a box, we were just looking at the medial wall, and again, these are some fairly important structures that or items that would be located on that wall. Again, that would be this surface here. Here again, you see the Eustachian tube coming out of the middle ear space. Here we have a view of the tympanic membrane, and I kind of like these ossicles a little better in the sense that they're kind of exaggerated, almost caricatures, but you can really see how they fit together there. And here you can actually see there is a tendon and a muscle attachment right on the stapes footplate. And this is what's going to activate the so-called acoustic reflex, which is one of the more important functions of that middle ear space. Again, here's the round window. And up here you can see the stapes footplate or the stapes bone really looking sort of like a stirrup. A person's foot would go kind of right through there. And then this oval shaped footplate fits right into a window into the cochlea. And if you look closely, you can kind of see the coils of the cochlea coming out there in that lighter color. Now, the tympanic cavity then is that middle ear space, and it has in it a few important structures. We've already mentioned the ossicles, the hammer, the anvil, and the stirrup, or the malleus, the incus, and the stapes. The malleus is attached directly to the tympanic membrane. The other bones are attached to each other. There's a specific location at which the malleus seems to be most firmly attached. That's the umbo. That will be right here, or right here, looking at it from that way, or right here, looking at it from that way. So right there is the firmest attachment, right there, the end of the malleus, and it would be right there if that kind person had not actually cut the tympanic membrane out. Again, these are bones that are connected to each other by joints. However, they do not articulate into the bones of the skull via any sort of joints, so they are actually suspended from that middle ear, the walls and the ceiling, if you will, of the middle ear space by those ligaments, hence their stiffness, but also their ability to be set into motion by the pressure of a sound, as opposed to having to be pushed physically by something solid. Let's take a look at the malleus here. Now this is the malleus next to a penny. It is, as you can imagine and as you can see, extremely small. It has these different parts to it, the so-called head of the malleus, which has that opening or that kind of concave area, which is where the incus is going to fit, the head of the incus is going to fit. The umbo, the connection point, would be down here at the end of the long process, or the so-called manubrium. And we also have a place where the tensor tympani muscle, which is another muscle for the acoustic reflex, is going to attach, and that's right here, this so-called anterior process. The lateral process kind of sticks out, bulges out into the outer ear space, and that would be kind of this part right here, which you can perhaps recall from another one of the images we looked at, kind of sticks out into the membrane. So the difference between that and the anterior process is that this is where the connection to the tensor tympani muscle will occur. The incus fits together with the malleus. The incus has this big part here. Again, big is relative. This is, again, a penny right there. And we see how the incus also has a long process coming off of it, and the malleus and the incus work against each other or move against each other in a lever-like manner. And then this lenticular process, which is this bottom part at the bottom right here, is where the stapes is going to actually fit in. Now, it's not the stapes foot plate, but it's going to be this part of the stapes, the head of the stapes, that fits in right there. It's been said that the most easily dislocated joint in the body is the incudostapedial joint. That would be the joint formed by this process and the head of the incus. However, it doesn't happen too often because it's very difficult to get the force directed right in there to make that joint disarticulate. But it is a joint, and in some people it does actually get disarticulated. The stapes itself is the smallest bone in the body. You see here really how it is shaped like a stirrup. And this is the foot plate portion of it. So this is the part right here that would actually fit into the oval window right there, or right there. So again, the oval foot plate of the stapes is what actually is going to fit into that opening in the skull called the oval window, which leads directly into the cochlea. And it is through that foot plate that all the energy that hits the eardrum will be sent. So it's almost like you've got a large surface area here collecting a lot of energy and then focusing that energy through this conductive system, through this mechanical vibrating system into this very small area. And in doing so, it increases the force with which that stapes is driven substantially. And that has to happen. That's important because, again, the inner ear back here is fluid filled, and it will require amplification of sound energy in order to be able to have that sound energy displace the fluids of that inner ear. As mentioned before, there are going to be two muscles in this cavity. And here we see the attachment for one of them. And here we see the attachment for the other one, the tensor tympani muscle and the stapedius muscle. The tensor tympani is the larger of the two, and it originates from the anterior wall of the middle ear space, inserting into the manubrium of the malleus at that anterior process. So again, if we shoot back to this diagram here, here's that anterior process. This is the side of the head out that way, so the front of the head must be coming out towards us from the screen. And there's your tensor tympani muscle. The stapedius muscle, as we'll see, is much shorter. Now the tensor tympani muscle is innervated, that is to say it contracts when stimulated by cranial nerve 5, the trigeminal muscle. It pulls the tensor tympani, or I'm sorry, it pulls the tympanic membrane, it pulls that malleus a little bit toward the front and toward the middle of the head, and in doing so it stiffens, increases the tension, it stiffens the ossicular chain. Again, if we add stiffness to the ossicular chain, that should change its transmission characteristics, and indeed it does. Adding stiffness to that ossicular chain, to that middle ear system, reduces the amount of low frequency energy passing through it. So if we increase the stiffness of the system, we shift the resonance frequency higher, and we reduce the transmission of sound energy flowing through the system, particularly at low frequencies. Now, that's fine, but it turns out that the tensor tympani muscle also gets contracted, also gets activated if somebody were to blow a puff of air on your eyeball or put something in your eye like a contact lens, or even brushed the side of your face with their hand, or even blew with some force on the side of your face, like on your cheek area. And so the tensor tympani muscle, although it does contract reflexively when we hear loud sounds, it also contracts when there are a variety of non-auditory stimuli presented to the listener or presented to that person. That is in direct contrast to the stapedius muscle, which will contract only when either an individual is anticipating a loud sound or has just heard a loud sound. It is attached to the stapes bone, and it is innervated not by the trigeminal nerve, but by the facial nerve, or cranial nerve 7. The stapedius muscle also tightens, stiffens the ossicular chain. It limits the stapes' range of motion. It limits the amount that it can vibrate in and out of the oval window. And again, it adds stiffness to the middle ear system, which means that it's going to shift the resonance frequency higher, but even more important, it's going to filter out or reject low frequency energy. And like I said, these muscles, especially the stapedius muscle, will contract even in anticipation of certain sounds, specifically the sounds of you chewing or talking. Don't forget that the output at your vocal folds, sound pressure level, is about 120 dB. It's a very high intensity sound right at your vocal folds. And that loud sound, that high level of sound, will radiate throughout the skull and could potentially even be present at damaging levels in the cochlea, unless that sound was attenuated somewhat by the stapedius muscle. This is probably a bigger deal for some of our mammalian friends like lions, for example, which can roar quite a bit louder at quite a higher level of output than we can talk or even shout. And it turns out that in mammals, the stapedius muscle will contract just before they are about to vocalize. In other words, when a dog is about to bark, just before it barks, this muscle contracts inside its middle ear, and in doing so makes that middle ear transmit energy less effectively than it would otherwise transmit energy, and in that way, it's kind of a protective mechanism even before the animal vocalizes. The same thing happens when animals chew, and the same thing happens when animals are exposed to loud sounds. That's where the reflex part of it comes in. When we are exposed to loud sounds reflexively, because we don't consciously make this happen, reflexively our middle ear muscles will contract and therefore make the middle ear less effective at transmitting energy, which is protective for the inner ear because not as much energy makes it in as otherwise would have. These are just some decibel values that for most normal hearing listeners will trigger the acoustic reflex. This 70 to 90 dB above threshold doesn't sound like a lot of decibels, I guess, but it is a very substantial increase in the sound power. So, for example, if it takes 1 unit of energy to stimulate your threshold, 90 decibels is actually 10 to the 9th times or 1,000,000,000 times more powerful than that threshold value. So that's, as you can imagine, a pretty substantial sound, a pretty high intensity sound. And again, the reflex contraction reduces sound transmission by quite a bit, by a factor of up to 10 to 20 times, especially at frequencies below about 1,000 hertz. We also use this reflex objectively in the clinic because it is a measure that a person does not have conscious control over, and so if we can evoke it, we can tell whether certain structures are functioning normally or not. So again, the contraction of this muscle down here and this muscle over here will tighten up this ossicular chain, make it vibrate less effectively, and in doing so, protect the inner ear in here from the movement of this stapes bone. If we stiffen that bone, if we stiffen this system, we make it so this bone doesn't move as far into the cochlea, and that is the protective nature of that reflex. Here's just another way to look at it. This drawing is perhaps a little bit clearer than the other one. Again, we're talking about a system of bones that conduct energy from one place to another, and when we modify the physical characteristics of that system by stiffening it, we modify the effectiveness with which it transmits its energy from the eardrum into the inner ear or the cochlea. A few words are necessary here regarding the Eustachian tube, or the so-called auditory tube, which connects the middle ear space here to the back of your throat, the nasopharyngeal region of your head and neck area. And this Eustachian tube has its primary function of aerating, that's A-E-R-A-T-I-N-G, aerating the middle ear space by allowing air to flow from the back of your throat up into this space. It's important that the Eustachian tube do that because the middle ear works best when the air pressure in here, in the middle ear, is the same as the air pressure out here in the outer ear. Now you'll notice the eardrum is there. It forms an airtight seal, watertight also, so you can be swimming and stuff and water will get into here, but hopefully it does not get through the eardrum, because if it gets into this space you can get an infection pretty easily. Also, air cannot flow through that space, and so the only way for air to get into that middle ear is through this Eustachian tube. The Eustachian tube typically is closed, but it can open under certain movements of your jaw. For example, if you swallow or chew gum or chew food, or even if you sneeze or cough, that Eustachian tube very often will open and then re-aerate, allow air to flow back up into that middle ear space. Here's perhaps an easier to imagine drawing of it. So again, here's the Eustachian tube. Here's your nasopharynx. This is kind of where the back of your nose meets your throat. And again, here's the eardrum, and you see this middle ear space doesn't get air through this pathway. It gets it through this pathway. And this is mucousy, sticky tissue And like the sides of your mouth and your tongue and your lips, it'll kind of stick together unless you force it apart. And it's not like you can actually open your eustachian tube just by thinking about it. You do other things that open it. Like I said, chewing or swallowing or moving your jaw around will very often be enough to get that opened up, and I'll show you how that works in just a sec. Notice how, just like we saw with the ear canal, the eustachian tube has an infrastructure that is partly bony, and that would be the lateral 1/3 of it, and then partly cartilaginous, and that would be the medial 2/3 of it. Here we are on the outside of the head, moving in toward the center of the head. Again, this is your nasopharynx, so this is kind of right at the top of your throat. So this is really toward the middle of your body, whereas all this is more toward the outside of your body. Netter gives us a very nice diagram of this. This would be a what kind of section, class? A sagittal section sliced right through the center of the head. Here's the opening to the eustachian tube. Here is your palate. Here's your soft palate. Here's your uvula, tongue, teeth, nose. You got it? Nasal cavity, right? Down here is your larynx. I know you've spent a lot of time talking about that. Epiglottis right there. And so this area right here is where the eustachian tube opens up into, and it would go from here out toward the side of your head, toward the middle ear space, and which would be kind of up there someplace, again going through the screen. There's some other stuff in the area that is worth noting. These are your palatine tonsils, otherwise known as your adenoids. And you can see how if these get swollen, they can actually push on the tissue around the opening to the eustachian tube and close it off. And the problem there is that if the eustachian tube remains closed for too long, that is actually a predisposing condition for a middle ear infection. If you're interested in how that happens, we'll talk about that perhaps when we talk about the testing of hearing. But really, that would be something that you would want to talk about in an audiology class. In any event, here's where the eustachian tube opens up, just superior to your palate, especially, in particular the soft palate area. And again, it is right in the area of where the adenoids are, the palatine tonsils, as well as the lingual tonsils, which we think of as the tonsils. If we look at it a little more close up, again, there's your adenoids. Here's the opening to the eustachian tube. To get up into the eustachian tube, you would be moving superiorly and laterally out toward the side of the head. If we strip off that mucosal skin layer, we see the cartilaginous infrastructure of the eustachian tube as well as the muscle attachments to it. Notice how these muscles are kind of flat and thin. They're almost like straps, and they really work simply by pulling on the eustachian tube when something else around them moves. So if you swallow and you drop your soft palate, notice how that's going to tug down on these muscles, and in doing so, afford an opportunity for that tube to open up. Movement of the jaw muscles up and down can also change the architecture in this region and allow for these muscles, again, in a strap-like fashion, to tug on the walls of the eustachian tube and open it up. The two main players here are the tensor villi palatini and the levator palatini, which we see right there. And again, we'll get there in just a second. The idea, though, is that this tube is, in some areas, very skinny, and opening it is not, for some people, not the easiest thing or the most routine thing. Those would mainly be individuals who had perhaps insufficient tissue here to allow for that tugging to occur. What individuals would those be? Well, those would be individuals with cleft palates primarily who are suffer from many of them suffer from chronic middle ear infections because their eustachian tubes do not open properly. The narrow part of the tube is termed the isthmus. That would be this area right in here where the tube is at its thinnest. And again, it does take some power to get that tube open sometimes. Typically, opening the eustachian tube is a more difficult proposition for small children, and that's because the eustachian tube for the smaller children is more angled more parallel to the ground than it is for adults. When we look more closely at the physiology of that system, we'll see how that works. But recognize for now that the one of the reasons why young children are more prone to middle ear infections is because their eustachian tube does not function as well. It does not open as easily as it does in adults. And again, just to get back to this image here, here's a slice through the head someplace where the eustachian tube can be seen sort of in cross section. And again, notice how this cartilaginous area and the wall of the tube are connected to this kind of strap-like muscle. And we see another one right there, the levator palatini. When the levator palatini contracts, it kind of spreads out and goes lower. It gets kind of thicker and shorter at the same time that this tensor veli palatini is tugging down on the walls of the tube. And when that happens, this sticky, mucus-lined tube can actually open up just a little bit, allowing air to flow from the nasopharynx up into that tube. Obviously, this tube would continue down into the nasopharynx and can allow air to flow that way. The air, once it gets through that tube, will make its way up into the middle ear space. Ideally, then, the air pressure in this space will be equalized with the air pressure in the atmosphere because your outer ear exposed to the atmosphere should be at about the same air pressure as the air in the back of your throat, which is exposed to the atmosphere through your nasal cavity and through your oral cavity. So what we'll do next time is look more closely at the function of some of these structures we've talked about with respect to both the outer ear and the middle ear. And then in a very short amount of time, we will be able to focus our efforts more on the inner ear and some of the pathways that convey sound up to the brain.